All right, I think we're ready to get started. If you guys want to take your seats. I'm assuming we'll probably have some people trickling in. I thank you who are not familiar with the Children's Hospital and found your way here, because I know this is a big campus and it can be hard to find your way around, so I expect we'll have some people trickling in as we go along. So thank you. Welcome to the first ever Minnesota Chapter National Pancreas Foundation event. For those of you who may not be familiar with the National Pancreas Foundation, they are a really great organization. They help patients with pancreatitis and pancreatic cancer. They sponsor research, do a lot of patient advocacy, help patients get to care. And the Minnesota chapter is brand new, within probably, the last 6 months or so. And Sonia Ariano is the leader of the Minnesota chapter and is helping put on this event. So thank you. Just a little housekeeping. There's breakfast out there, so if you haven't had a chance, please go ahead and grab some breakfast. We'll have a little break after the first session if you haven't had a chance. And then there are restrooms right outside this auditorium to the left, so if anyone needs a restroom, it's right out there. We'll be organizing this into 3 sessions. So the first session is fairly brief, but we're going to talk about endoscopic therapy in the setting of recurrent acute and necrotizing pancreatitis. The second session is really pediatric focused, and then the third session is adult focused. But that being said, I wouldn't say that the information in those sessions is necessarily entirely specific to just kids or adults. I think you'll see that there's a lot of relevance to both sides of the spectrum. So our first speaker, for each session, we're going to have a patient can talk a little bit about their experience for about 10 minutes and present whatever they want to present. So our first speaker is Mr. Gene Veeder. He comes to us from a few hours out to the west, so he's kind enough to make the trip, as were some of our other patients. He is a patient of Dr. Guru Trikudanathan, who is going to speak next. So I will introduce Gene, and then after Gene will be Dr. Guru.
Well, thank you very much. I come to you from about 650 miles to the west of here. Yesterday I was feeding my cattle in 2 feet of snow and about 30 miles from anywhere. I'm from a real remote part of western North Dakota, in the Badlands of western North Dakota. It's fun to be back here and feel healthy, because my time here was spent with much pain and much disorientation, and we feel so close to Dr. Trikudanathan, my wife and I do, that it's almost emotional to see you again, because when I left here, it was not a good situation. Sure. Okay, very good. All right. I want that first one that says close up on it. I wanted to, yeah, right there. I wanted to show you what I looked like when I left this place about a year ago. A year ago, I was still struggling with pancreatitis. We got home in February of last year, but this whole journey started in October of 2017, Halloween night at the ranch. I suffered extreme stomach pains. We're about 28 miles from a local hospital, and so ambulance service out there is very difficult, so I got in my vehicle. My wife wasn't there, and drove to the local hospital, and they quickly diagnosed me with a gallbladder attack. And ambulance then me to about 3 hours southeast of Bismarck, and they started the process there. And of course, what they found out is that I had a gallstone that had migrated to my pancreas. So it looked like it was going to be just a normal gallbladder attack, but they did find some problems that we had there, so they had to wait and take those stones out and wait a couple of days until they were able to remove my gallbladder. Took that 3 or 4 days of recovery, and I was really struggling, but I went back to the ranch, because that's what we do when we don't want to be sick. We need to get home right away. And Dr. Trikudanathan knows how many times I begged him to please let me go when I was not ready. I was obviously not ready to go home. I went home to the ranch. We were shipping cattle at the time, and I just felt like I needed to be there, and I really hit a terrible place and became very, very ill at that time, to the point where we had to get back to Bismarck. They looked at me again and really struggled with what happened at that time. Much of this stuff I don't remember, so I'm taking it from my my wife, who, by the way, was the single source of support for me through all of this. Now, I don't want to get emotional here, but I could not have done that without her. Because when you're so sick like that, you don't know. You'll do anything anybody tells you. I started filling up with fluid. The doctors there couldn't figure what happened. During that period of time, I'd went from about 125 pounds to almost 300 pounds. And when I arrived here, then I just was in a terrible way. The interesting situation was that one of my best friends a year and a half had died from pancreatitis. In the same scenario we had, he got to Bismarck, and they started working on him, and it just escalated, never came out of his coma, wound up getting back to University of Minnesota, but he never did come out of that. But at that time, my wife realized that this was the place to come for pancreatic issues. She was the one that did that. She was the one that convinced those doctors that I have to get to U of M in Minnesota. And it was quite a struggle, honestly, that they didn't, and we didn't find that here, but there we did find that they weren't taking her serious. And so with much convincing and a good support from the staff there, but probably not the physicians as much, they wanted to take care of it. We don't think we would have survived. Once it got that bad, they air evac'd me to here, and then it came to your care. And I know Dr. Guru will tell you what that was like. It was very, I just was at the edge of life and death many times during that process. And I guess, we spent most of that time in ICU and just trying to stabilize me, and I, of course, wasn't quite aware of that. It was extremely painful situation, and I struggled quite a bit attitude-wise, and I would have taken the trip anywhere to see this doctor because I wanted him to see me how I am, not how I was as a patient, because I really was struggling. I just really struggled. I was emotionally struggling a lot, and I was lonesome, and all those things that happened to a patient. But at the end of the day, I guess we got here right after Thanksgiving, and I look at Beth because she knows when I was here and when I wasn't. And we were much of that time we were in the hospital and wound up for about a month in rehab after that, and I left in February. One of the big challenges we had, and I wanted to make sure that I noted that as being that far away, we didn't have any aftercare to speak of. So Beth had to be trained and taking care of all of the tubes and all of the things that were there. It was really a challenge for her, and it was really stressful for her because there were 3 months of really strong recovery time where I just couldn't get off the couch and just couldn't. I mean, I was so weak. And I had got down, that was about a 130-pound shift from one side to the other. The biggest challenge we had during that period of time was probably getting information at the University of Minnesota. We know was the right place to be, but there weren't support areas out there to tell us. We had this, I don't know if you remember you do remember the red tube there. We didn't know what to do with it. And we couldn't get the care back there, and it was so hard to get back to University of Minnesota. If we would have been here, this would have taken care of. It actually wound up through I don't know what happened, but the thing fell out eventually. And, that's my short version of what the struggle. It was a life-changing struggle. The overriding piece was that I had just lost a friend to this disease. When I saw him, I never saw him awake again. I had not heard of, I didn't know I had a pancreas before this. And so he perished from that. And then I'd also, 4 years previous to this, I'd had a aortic dissection. I don't know if you're familiar with that, but I survived an aortic dissection. So I was out on the ranch then too, and it was 4 hours before I got to a remarkable surgeon in Bismarck that had been trained specifically in the technique that took care of my aortic dissection. So I don't like to be a sick guy. I don't want to be a sick guy, but I've had 6 or 7 years of recovering, and I wanted Dr. Guru to see me that life is pretty good. My only real challenges, I'd had one challenge that I'd corresponded with the staff here. We were on, I just lost the name of the enzyme medication that I was on. I was continuing to take it, and I wound up getting very sick at home. and just couldn't figure out. I went backward real fast. So we called down here and did some check and went off that medication, Creon. Went off Creon, and I've been good ever since. My body tells me when I'm bad. And so that's really been the real issue. Because I'd lost so much weight, my knees and my shoulders and I have a hard time physically getting back to where I was before. But I'm living a pretty normal life right now. And so I hope that the message can be, because I didn't know, and I talked to Dr. Guru about it many times, am I going to be an invalid the rest of my life? And that was really hard on me, and that was my struggle. Within of May of last year, come on, that again? Okay. I just wanted to show you a little bit of my life. There was me in May last year. My brother and my brother-in-law. One of the things that I really wanted to tell you is I have a family. My wife's family was somewhere in the Minneapolis area, somewhere in the far area. Were there every day. My wife was there every day. My brother and my brother-in-laws, they made sure that I wasn't by myself. And I didn't think it mattered at the time, but it mattered in every way, shape, and form to have the family there and understanding. Beth became, I think, a professional in pancreatitis in terms of, and Dr. Guru was so good about explaining this process for us. But that's my life. We're back to life on the farm the way it. This is why we. This is why you want to wake up in the morning. Those are my grandchildren, and that was in July at the state fair, and I've returned my life back the way it was. If you could have seen me when I left this place, you would never believe that I would have my back this way. So I feel that God found Dr. Trikudanathan, and he went through all of this training, and his team went through all this training, and you spend this time in your life with me. I never see you again, but I get to live my life, and I just am so grateful to, hundreds of people that I've dealt with this disease, and they treated me like their best friend and the best, most important person in their lives, and then you move on to other patients, but I get to have my life back. So that's my life, and I think that's probably the story that I need to tell, is that you can survive this thing. I don't think anybody would have thought I would have ever survived. It was so dark. It was such a dark thing. The thing that is a struggle, the biggest struggle I had with that still is the mental part of it. I struggled during my hospitalization with delirium, and I struggled getting those thoughts out of my mind. It was you go to a bad place, you don't realize what's happened to you, but I said I've been to hell, because that in your mind, I was in another place almost all this time. A lot of time I felt I was on a ship out in the middle of the ocean, and these people were just partners with me on a ship. I felt that I returned to the hospital when the nurses would ask me, Mr. Veeder, can you say where you are? I want to tell them I'm on a ship. But I knew the right answer was I'm in this hospital. I thought I came through a clock in the wall to get back to the hospital. It was I don't know why people do drugs. So I'll tell you that. So thank you for having me. I really appreciate coming back here. And I think the person you need to hear from is my doctor. So thank you very much.
I don't think we could give a better introduction to Dr. Trikudanathan, so please go ahead and.
Good morning to one and all present here, and thank you, Mr. Veeder, or Gene. I should call you Gene. It meant a lot to me. You came 650 miles just to share your story, and your story is very similar to a lot of our surviving necrotizing pancreatitis patients. And I do want to focus my talk today on necrotizing pancreatitis. I'm one of the PancBilly staff at University of Minnesota. The following are my disclosures. I do want to review some of the terminology and talk a little bit about the endoscopic step-up approach, what we how we cared for Gene, and some of the long-term complications of necrotizing pancreatitis today. So to start with, what is pancreatitis? What is acute pancreatitis? So acute pancreatitis is a dynamic inflammatory process involving pancreas and peripancreatic tissues, very rarely remote organ systems. And some unfortunate patients like Gene, they were septic and they were really have every remote organ which could be involved was involved in them, but it's not very common. And acute pancreatitis is the most common gastrointestinal cause for inpatient admission. It poses an enormous financial burden. Roughly 274,000 admissions every year, nearly $2.4 billion are spent in acute pancreatitis. So to diagnose acute pancreatitis, we take into account two of the three major criteria: acute abdominal pain, elevated lipase levels. The lipase and amylase are pancreatic enzymes. They get elevated when you have an acute inflammatory event, and pancreatic inflammation on the CAT scan or any sort of cross-sectional imaging. If you see here, this is the normal portion of the pancreas, and this portion here is all necrosed and inflamed. Fortunately, necrotizing pancreatitis is not that common. Interstitial pancreatitis, that accounts for 85 to 90% of acute pancreatitis. And by interstitial pancreatitis, I mean that when the pancreas perfusion is preserved, and here we can see some fat stranding here, but overall the outline of the pancreas is preserved. And this accounts for 85 to 90% of pancreatitis. And these patients have a really great survival, less than 5% mortality, no long-term complications. Some of them do develop chronic pancreatitis, but overall a very good outcome. But the focus today is going to be on necrotizing pancreatitis. This is where the pancreas and the peripancreatic fat gets involved. And this is because the pancreatic perfusion is compromised. Just like how we have the golden hours for heart, we also have the golden day of resuscitation for the pancreas. The first day when a patient shows up, if he gets adequate fluid resuscitation, and then the pancreatic microcirculation is usually preserved, and they don't end up getting necrotizing pancreatitis like this. And the mortality we are talking about is as high as 20 to 30%, particularly when these collections get infected. Again, necrotizing pancreatitis is defined as non-enhancement of pancreatic parenchyma on a contrast-enhanced CT scan. A few terminologies here. This is important because the way we manage necrotizing pancreatitis depends on recognizing what type of collection a patient has. Again, you have an acute fluid or necrotic collection when it happens within the first 4 weeks. And when the collection gets more well demarcated, it's either a pseudocyst or walled-off necrosis. And when we talk about walled-off necrosis, these collections could be, the maturation could range from anywhere between here to here. As you see here, the wall is very well encapsulated, and but whereas here the wall is partially encapsulated, and here it's poorly encapsulated. And necrosis can involve pancreas alone, or the peripancreatic fat, or it could involve everything. And Mr. Veeder had a collection which involved everything, and we will talk about it very shortly. So again, as we talked about, it's very important to recognize the collection, the type of collection, because that dictates the management. An acute fluid or necrotic collection, in other words, a poorly demarcated collection, we wait and delay as much as 4 weeks or longer. A pseudocyst, which is essentially a completely encapsulated fluid collection, we drain. We do not need to debride, we just drain. On the other hand, walled-off necrosis, we not only drain, we also have to go into the cavity and debride all the dead pancreatic tissue. So not every patient needs to be intervened. There are certain criteria for intervention, our major indication, more than 80 to 90% of the patients, we intervene when we suspect infection. And very rarely we intervene on sterile collections. Sterile collections, we intervene only when patients have gastric outlet or intestinal or biliary tract obstruction, or they have like a persistent symptoms of unwellness, and sometimes rarely with disconnected pancreatic duct syndrome. The timing of intervention, we try to wait. Sometimes we can't, but we try to wait as long as 4 weeks. Again, essentially to let these collections demarcate, encapsulate. And early intervention, again, early surgical intervention has been associated with very poor outcome. So when it comes to how we would intervene, the first picture here shows the traditional method which we have been doing in many places still, but which many people have been doing for many years, where they openly open the abdomen and debride the dead pancreatic tissue. And the second picture here shows things like percutaneous drain here and what they call as video-assisted retroperitoneal drain, debridement. Then the picture here shows what we do often, endoscopic drainage and debriding the collections all endoscopically. But again, it depends on the location of the collection. Sometimes if the collection is in the deep pelvis or deep retroperitoneum, we do need to put a percutaneous drain. Sometimes we do have to put a scope or a sinus tract endoscopy to do this. In a lot of patients, we do more than one of these two minimally invasive management. Again, open necrosectomy, traditional management for necrotizing pancreatitis. And these patients, they open up the abdomen and they carve out all this pancreatic, dead pancreatic tissue. It has been associated with 34 to 95% of patients end up with complications and death in 6 to 26 patients. Even those who survive end up having lifetime of endocrine and exocrine insufficiency, diabetes, chronic pancreatitis, and fistulae and hernias. A typical example is one of Dr. Bielman's patient. He inherited this patient after open necrosectomy. This patient had a massive hernia. If a patient gets opened up these days, this is what it would end up being. So then what do? We do endoscopic transluminal drainage. This is a picture of the collection here, and we use what we call as an endoscopic ultrasound. This is a scope fitted with an ultrasound probe, and we put a stent between the stomach to the necrotic collection under endoscopic ultrasound guidance. And the stents we have been using these days are the lumen opposing stents here. And then after a week or so, once the tract or the cysgastrostomy tract is formed, we go and debride these collections. It's a long and laborious process, takes hours and hours in the operating room. We go and debride and remove all this dead pancreatic tissue through the mouth, and ultimately the collection ends up with fine granulation tissue. So there are other ways of draining these collections as well. Depending on the location of the collection, sometimes we can't get away just with one cysgastrostomy. We do have to put a cysgastrostomy here, a cysduodenostomy, and another drain through the duodenum. And this is what we call as a multi-gateway technique. And very often we do have to, for collections close to the deep retroperitoneum and collections involving the pelvis, we do have to put in percutaneous drainage as well as cysgastrostomy stents. And Gene here had 3 percutaneous drains, 2 cysgastrostomy stents, and and getting rid of these percutaneous drain, it's a task by itself. But we do have to do this, otherwise the collections, until all the collections are gone, that it's still a seat of infection. And we have found from other centers that combining the endoscopic and percutaneous drainage decreases the hospital stay. It's still 26 days, but 26 days is better than 55 days. And it reduces the time for removing the drain as well. And this is a short video showing why we combine endoscopic and percutaneous drain. The idea is that we flush the collection through the percutaneous drain so that it egresses out into the stomach, as we see in this picture. Again, we flush the percutaneous tract every 6 to 8 hours, and the collection egresses through the stomach, and ultimately we can remove it or the patient passes it on the stools. And sometimes it's not enough if we just put drains. We may have to go and debride this collection. Remember, these are all solid necrotic chunks. And this is a video edited by one of Dr. Freeman, my mentor here, who's here. It's Dr. Freeman here passing the scope through, this is the sinus tract endoscopy. He's passing the scope through the percutaneous tract. And I have a scope coming through the mouth. And again, Dr. Freeman is trying to remove all the necrotic debris from the percutaneous tract. And I'm trying to remove it through the mouth. And as you see, there's a lot of dead pancreatic infected tissue here. And we snare it like this. And we ultimately take it out. And this is how we deal with deep retroperitoneal collections. And we take this big chunk of necrotic pancreatic tissue out through the stomach. And this is Dr. Freeman again, placing the percutaneous drain, the red tube, which Gene talked about. We try to place it under fluoroscopic guidance. And ultimately, the goal is to have the percutaneous drain back until all the necrosis is removed. And again, Dr. Freeman is demonstrating how after he injects through the percutaneous drain, this collection is all coming into the tissue is coming into the stomach for us to remove it. So what are the outcomes of our endoscopic step-up approach? Why do we do this rather than open surgery? Endoscopic step-up approach results in reduced physiological stress. We go through a natural orifice, so the patients have reduced physiological stress. There is reduced risk of new onset multi-organ failure, shorter hospital stay, reduced cost. And most importantly, it results in significantly reduced fistulae. And fistulae are some of the major reasons for morbidity, and they have no real difference in mortality. It's been studied multiple times, 3 major randomized controlled trials, including one from United States called the MISER trial. And all of them show the same thing. The mortality is comparable. In fact, other studies have shown that the mortality is even lesser. But the complications, the hospital stay, the multi-organ failures, they're all less with endoscopic step-up approach. But it's not everybody has a good story. We do run into complications. Most commonly, common complication is bleeding. We do get bleeding into the necrotic cavity. This is a big vessel sitting right at the floor of the necrotic cavity. And this is Dr. Freeman again placing clips to prevent or stop this bleeding. And we do have to sometimes embolize arteries to stop bleeding. And this is a kind of fortunately uncommon at University of Minnesota. This is a perforation because a perforation caused by placement of the stent. We haven't had this fortunately happen that many times at University of Minnesota. And we have had one fatal air embolism where when we were using air, now that we are using CO2, this is not happening that often. But typically a patient like Gene, what we do is multimodal approach, and we sit every Thursday in a multidisciplinary conference with Dr. Bielman, Dr. Freeman's guidance to go over every single patient we are managing. We decide how to start, how to proceed, and we review every CAT scan. And this is a patient who has a deep retroperitoneal collection like this, and we had to put in multiple drains, a cisgastrostomy drain here, a cisduodenostomy drain here, bilateral percutaneous drain. We are very conscious of the fact that patients need nutrition. This is a nasojejunal tube we have placed for enteral nutrition. We avoid total parenteral nutrition or TPN. And again, we go in after the tract matures and do debridement. Again, this is the picture showing the retroperitoneal drain. And then we sometimes have to do sinus tract endoscopy. And after 3 to 6 months, the collections completely improve. So then the question is there a role for early intervention? And this early interventions, again, traditionally we wait for 4 weeks. But somebody like Gene, he came in with sepsis and he was on three pressors needing to support his blood pressure when he came in. He was in the ICU. And we didn't think we have to abide by the arbitrary 4-week cutoff. We had to go to the operating room and drain him before 4 weeks. The reason being, we do have a study here, which we published in the American Journal of Gastroenterology. Early interventions, especially in medically refractory patients who are on pressors, it's associated with improvement in organ failure. Here we see the renal failure needing dialysis. Patients have improved within a week after endoscopic drainage. And again, patients are off ventilator within a week. And also the patients like Gene, they completely improve and they are tapered off the pressors within a week. And this is our outcomes for our early intervention. We studied 76 patients whom we drained before the 4 weeks. The mortality was marginally worse. Again, these are critically ill patients staying in the ICU. And obviously, the length of hospital stay and ICU stay was little more, but we did not have any complications in the early interventions group. So it could be done, but again, it should be done in a major tertiary referral center like us. And necrosis is also associated with complications. And the first and the foremost is the psychiatric complication. Again, what Dr. Freeman appropriately calls as post-pancreatitis stress disorder. And not just for the patient, for all the family members as well. Managing these patients takes a heavy toll on their life. And patients are depressed, their family members are depressed. We are talking about 3 months in ICU. We do not know how they are going to fare, and it's a lot. We are very conscious and cognizant of this, and we sometimes support them. We do tell them there is light in the end of the tunnel. Patients sometimes get gastric outlet obstruction. Remember, we talked about fistulae. They do get clots because this is a major inflammatory event. They do get clots in the portal vein, superior mesenteric vein, splenic vein. They may need anticoagulation for this. They could get life-threatening pseudoaneurysms, and these are vessels which rupture and cause massive bleeding. And once they get out of the hospital, we do have to deal with disconnected pancreatic duct syndrome. Remember, a portion of the pancreatic duct is eaten away by necrosis. We do have to deal with pancreatic and enteric fistulae. And then lifelong, sometimes patients get diabetic. They do get exocrine insufficiency, and they could get chronic pancreatitis as well. So this is not an easy disease. It's highly complex, has many layers to it, and you need a multidisciplinary team. Fortunately, at University of Minnesota, under Dr. Freeman, Dr. Bielman's leadership, we have been fortunate to have a really robust group with surgery, endoscopy leading the show, with surgery and IR available, and we discuss with the critical care and the primary care doctor. Team approach is really important. And again, when a collection, depending on how encapsulated it is and the location of the collection, we either do endoscopic drainage, or sometimes we have to do endoscopic and percutaneous drainage. If the collection is far off from the stomach, we start with the percutaneous drainage and take it from there. And we do open surgical necrosectomy only if we fail or if the patients get sicker. Again, I can't thank enough and I'm very fortunate to be in this incredible severe acute pancreatitis group led by Dr. Freeman here and Dr. Bielman. And these are my colleagues, Dr. Mallory and Dr. Amato. We all share the same passion for managing necrotizing pancreatitis. And every day we see Gene and other patients. That makes our day really, this gives meaning to why we all went to medical school and underwent 14 years of training. All right, thank you.
Anyone have any questions that they'd like to ask of Dr. Guru or Gene? Otherwise, no questions yet, but Dr. Guru will be around for a few more minutes. Then he's actually working today, so he has to leave us, unfortunately, and we'll take about a 10-minute break, and then we'll reconvene on the pediatric pancreatitis session.
You have been disconnected from the meeting.